Thank you all for joining us today for our webinar, Oasis Basics. As mentioned, this recorded webinar will be available to everyone after its conclusion. My name is Dr. Debbie Nixon. I'm with Health Services Advisory Group. I work as a corporate advisor out of our Phoenix, Arizona office. I'm joined today with several individuals from Health Services Advisory Group, but I'm working on this particular task with Deborah Bueller, who is our contact for Arizona, California, and Ohio, Diane Cronus, who is working with us out of our Florida office, and Gwen Williams from the Virgin Islands. So we really appreciate everyone being here. What we wanted to do before we get started is just do a very, very brief overview of Health Services Advisory Group, which is the Quality Innovation Network, Quality Improvement Organization. As most of you may know, we are representing Arizona, California, Florida, Ohio, and the U.S. Virgin Islands. And our the slide here shows that in those states, those 5 states, we represent about 25% of the nation's Medicare beneficiaries. And to all of us, that means that we have a tremendous amount of data that we can really begin to use to understand the population, especially in our home health agencies. Health Services Advisory Group is working primarily on this particular task in 2 main initiatives with our home health agencies. The first is the Quality Improvement National Cardiovascular Campaign that we're working on with HHQI. This is to really work with you all to make improvements in cardiovascular health for your patients. It's data-driven. We're representing nationwide about 14,000 home health agencies. And in our 5 states, we're working very directly with about 802 who have expressed an interest in working with us on this campaign. Most of you are invited today. We had about 250 sign up for this webinar, and we're very excited about the topic because we think it goes very hand in hand with our initiatives as well as something as important as Oasis. This is aligned with the Million Hearts Initiative, and the main focus of this campaign is to really help you achieve 5 milestones. And this is really working on quality improvement for you. The next slide shows that these are the 5 milestones that each of our home health agencies, we are working with them to hope to achieve. And you can see here that 29% of the home health agencies that we are working with have achieved milestone 1, which is attending at least 1 cardio LAN with HHQI. You can see here that the majority of home health agencies have actually registered for data access, which is milestone 2. And a smaller percentage reaching data abstraction, which is milestone 3. So 4 and 5, as you can see here, we have not gotten to that point yet with you all, but we have until July of 2019 to work with you to accomplish this. So we're really hoping that after today's webinar that you will get back in touch with us if we can help you in any way to reach the milestones that we're all working towards. The second initiative that we're working on is our immunization initiative, and this is to work with you directly on improving your immunization rates, which, as we all know, aligns with the Healthy People 2020 goals. The national goal is to have 70% influenza, 90% for pneumonia, and 30% for zoster, which is the absolute immunization rates, which we hope to accomplish. For Health Services Advisory Group, our absolute rate of 90% is what we're striving for. And this, as we know, are included in your star rating. So again, we hope to get any questions as a follow-up, work with you in providing any technical assistance that we can to help you achieve your goals as well as ours. This next slide shows the 2 initiatives. the HHQI, cardiovascular, and the immunization. And as you can see here, in California, we have 290 home health agencies working with us in HHQI and 130 of them in immunization. In Arizona, we have 82 working with us on the Home Health Quality Improvement Initiative, HHQI, and 25 working with us in immunization. Ohio and the Virgin Islands are only working with us on the cardiovascular, which shows the numbers here, 158 in Ohio and 2 in the Virgin Islands. And in Florida, we have 270 home health agencies working with us on the cardiovascular and 111 working with us on our immunization. As I mentioned earlier, these are the contacts for your states. We would welcome any questions or concerns that you have. And for your information, we've also attached as an additional slide the Oasis educational coordinators for each of the areas. So if you have questions, feel free to contact them directly. We are focusing today on Oasis and providing you an understanding and importance of the data. And we're very fortunate to have with us today Ms. Shirley Newman, who is a registered nurse and who is the Oasis Educational Coordinator for the Arizona Department of Health Services. Shirley, I'll turn this over to you.
Thank you so much, Dr. Nixon. Good morning to all of you. First of all, we want to take this time to thank Dr. Nixon and her team for the opportunity to work with them and coordinate this webinar. It's an honor. Very, very special thanks to all the participants for taking the time to join us. We know your time is extremely valuable. I've been a surveyor with the Arizona Department of Health Services for 19 years, and my disclaimer is I am not an expert on anything. You are on the front lines, you, the home health agency staff, you're the experts. And I want to acknowledge that. And our goal here is to work with you and learn from each other with a common goal of ensuring the safe, quality care for patients. That's number one. So during our initial conversations with Dr. Nixon and her team, we discussed how best to approach this. And Oasis is so complex, so many different levels, and because we only have an hour, we decided that we're just going to start at the very, very basic. So our presentation is very basic and touching on the who, what, whys, and hows of entering data into the Oasis. We won't be able to go into a great amount of detail into each and every question, but we're hoping to prepare you with some basics, including, at the end, some valuable resources. Okay, so sorry, just a second here. So the objectives this morning are, and this afternoon, to those of you in the afternoon, to provide an overview of the Oasis process, to emphasize the purpose, why there is Oasis and the data in there, and the understanding of the processes to accurately reflect patient outcomes. I'm sorry, we're having a little...
Shirley, I can help advance the slides for you. Just let me know when.
Okay. So what is the Oasis? It is the Outcome Assessment Information Set, OASIS, which is a standardized data collection tool, instrument, and includes 100-plus items and questions collected at various time points. And it is developed to measure patient outcomes. So the next slide. The Oasis is a data set comprised of domains of patient tracking, clinical record items, history and diagnoses, living arrangements, sensory status, integumentary status, respiratory, cardiac, elimination, neuro-emotional behavioral, ADLs, IADLs, medications, care management, therapy need and plan of care, emergent care, and discharge. It compares patient outcomes at 2 points in time and utilized to calculate payment algorithms for Medicare PPS. Submission of Oasis is required to participate in the Medicare program. A little bit of history, very little. Home health agencies began collecting and transmitting Oasis data for skilled Medicare and Medicaid patients, except for maternity patients, in 1999. So you can see over the years there have been a number of revisions, with the most recent one being October of this year, and incorporates the diagnostic items consistent with ICD and PIN. So believe it or not, over the years, the data set has been streamlined with concerted efforts by CMS to eliminate unnecessary or redundant data collection and actually to reduce and minimize data collection and burden on our patients and you. The Oasis data use, the data is used for quality reporting and, again, for prospective payment system reimbursement. The data items measure patient outcomes and patient risk factors. Quality outcome measurement is the measurement of changes in a patient's health status between 2 points of time. And we'll go over those time points a little bit later in the presentation. Outcome of care data reflect the quality of care provided to the patient, and it's called quality data or quality outcomes. Quality outcome episodes, or an outcome measure, are calculated from data collected at 2 points again. A quality episode is not the same as a payment episode. The end result, it compares patient status at beginning and end of care episodes. A care episode starts at the start of care or resumption of care and ends at transfer or discharge. It also reports improvement, decline, or stabilization. For utilization, calculates rate that specific services are utilized, such as acute care hospitalization, use of the emergency department with hospitalization, or discharge to the community. So slides 12 and 13, the process of care data items document whether certain evidence-based practices were implemented. Process items collected at start of care, resumption of care, document assessment and care planning interventions, such as whether the patient was assessed to be at risk for certain conditions like pain, falls, or pressure ulcers, whether interventions to address the conditions were incorporated into the plan of care. These items refer to assessments that were completed and orders included in the plan of care within the 5-day start of care period or the 2-day resumption of care period. Process items collected at transfer and discharge time points include documentation of interventions implemented as part of patient care at the time of or since the most recent start of care, resumption of care, or follow-up Oasis assessment. Process items collected at transfer and discharge may require a clinician to review documentation of care provided during the home health episode in order to accurately complete the items. Note that this review must consider care provided by all disciplines and is not limited to care provided by the discipline of the clinician completing the Oasis assessment. The review can be made in several different ways. The care provider may find it necessary to review clinical notes, including the plan of care, updated orders, and visit notes. The agency may elect to create a flow sheet when appropriate with parameters that are checked off at each visit. Regardless of the technique that the agency chooses, the processed data items completed at transfer and discharge will require knowledge of patient symptoms, initial and subsequent physician orders, clinical interventions performed to address patient symptoms that were present at the time of or since the most recent prior assessment. Okay. Again, the outcomes of care impacted by patient's home environment, the caregivers, physician practice patterns, and generally represent care that is directly within the control of your agency. A little bit about quality reports used by CMS and your agency for quality initiatives. The types of reports we have are the outcome-based quality improvement, OBQI, outcome-based quality monitoring, OBQM, and the process-based quality improvement, PBQI. A little bit about the Home Health Compare. So all Medicare certified home health agencies are potentially eligible to receive quality of patient care star ratings. In addition, home health agencies must have been certified for at least 6 months and must have 20 or more complete episodes of care during the 20-month reporting period for at least 5 of the 9 measures. Basically, recommend you all go on, if you haven't already, go on the website and look at the frequently asked questions by home health agencies about what the website means to you and your agency. It's very valuable information out there. So the subset of Oasis-based quality performance information posted on the Medicare website, process of care measures, their outcome measures, improvement measures, healthcare utilization measures, and patient experience of care survey results. For reimbursement, the reimbursement, as you know, is provided under the Medicare Prospective Payment System, PPS. It predicts costs to provide care to a specific patient base on certain patient characteristics, functional ability, and service utilization. It's based on the 60-day payment episode, and it factors in a subset of the Oasis items. It assigns the Medicare patient to a group, to a home health resource group, or HHRG, and other payers may use PPS-like payment models. So how do we get the Oasis data? Oasis data are collected as part of the comprehensive assessment required by the Medicare Conditions of Participation, COPs. So what you need to know, it's very important that Oasis is not intended to represent a comprehensive assessment in of itself. And home health agencies are expected to incorporate the Oasis items into their own comprehensive assessment documentation and to follow their own assessment policies and procedures. So, as you know, surveyors were always saying, what's your policy, what's your policy, what's your policy? You're all free to arrange or rearrange the Oasis item sequence in a way that permits logical ordering within your own forms as long as the actual item content, skip patterns, and Oasis number remain the same. So as with other comprehensive assessments, Oasis data are collected using a variety of approaches. Obviously, observation, interview, review of pertinent documentation such as hospital discharge summaries, discussions with other team members where relevant, for example, physicians to clarify diagnoses, and measurements such as intensity of pain. Keep in mind that Oasis data should be collected at each time point based on a unique patient assessment rather than carrying data over from a previous assessment. Data collected from the comprehensive assessment form the basis of the physician-ordered plan of care, and there needs to be a correlation between the findings from the assessment and the plan of care. The conditions of participation revised in 1999 are 42 CFR 4.11, release of patient identifiable OASIS information, the 42 CFR 4.20, reporting OASIS information, and 42 CFR 484.55, the comprehensive assessment of patients. The comprehensive assessment condition requires the agency to identify the patient's need for home care, to meet the patient's medical, nursing, rehab, social, and discharge planning needs. It also identifies the patient's eligibility for the home health benefit and homebound status for Medicare patients. Again, the comprehensive assessment requirement must incorporate the OASIS data set in a clinically meaningful way and exactly as written as part of the comprehensive assessment. OASIS assessment required for skilled Medicare. The assessments are required for this group: skilled Medicare, Medicaid, adult, non-maternity patients. One of the resource informations are the OASIS Guidance Manual, Chapter 1, Introduction to OASIS, and Appendix A, OASIS and the Comprehensive Assessment. We're going to talk about if there are any of you out there that don't have manuals, we're going to help you with some resources to locate them and get trained on them. Okay, the eligible patients for home health, they're collected for, again, Medicare, Medicaid, 18 years and older receiving skilled nurses, services. They're excluded for pre- or postnatal conditions, excluded for patients receiving only personal care, homemaker, or chore services exclusively. As you know, not all OASIS items are completed at every assessment time point. So understanding the time point definitions is critical to ensuring accurate and complete data collection. Okay, so all of these collection and completion time, all of these assessments, with the exception of transfer to inpatient facility and death at home, require the clinician to have an in-person encounter with the patient during a home visit. The transfer to an inpatient facility requires collection of limited OASIS data, most of which you could obtain through a telephone call. Not all OASIS items are completed at every assessment time point. Some items are completed only at start of care, some of them only at discharge. So the table of items is to be used at specific time points. At the start of care time point, the comprehensive assessment should be completed within 5 days of the start of care. At the resumption of care, the comprehensive assessment must be completed within 48 hours of return home after inpatient facility discharge. For the transfer to inpatient, discharge from home, or death at home, and other follow-up, the assessments must be completed within 48 hours of becoming aware of the transfer, discharge, death, or significant change of condition. Okay, so who completes the OASIS? Registered nurse, physical therapist, occupational therapist, speech language pathologist, or speech therapist. Who cannot? An LPN or LVN, PTAs are physical therapy assistants, OTAs, occupational therapy assistants, the MSWs, Masters of Social Work, or the home health aides are not permitted to complete the assessment. In cases involving nursing, the RN completes the comprehensive assessment. Any discipline qualified to perform assessments, an RN, PT, speech, or OT may complete subsequent assessments for a therapy-only case. Let's see. I know we're running out of time, so I'm going to try to speed up through here. So you could, again, for therapy only, when no nursing needs, it's acceptable for a PT or speech to conduct and complete. OT may conduct and complete when the need for OT establishes eligibility. So let's get to the meat of the actual completing of the tool. So it really is, it's just really critical, obviously, to ensure the information entered into the Oasis is accurate. There needs to be a single person that completes the Oasis. You really can't have an RN that starts an Oasis and have a different RN finish it. It needs to be a single person. Oasis conventions, rules to follow when completing. There are 16 general conventions, 3 conventions specific to ADLs, IADL's domain, and reference manual, again, is the Oasis Guidance Manual, Chapters 1 and 2. So convention number 1, report what is true on the day of assessment unless a different time period has been indicated in the item or related guidance. So the day of an assessment is defined as the 24 hours immediately preceding the home visit and the time visit for the home visit, or the time spent for the home visit. Care episode is also called a quality episode. Begins with the start of care, resumption of care, and concludes with a transfer or discharge. Convention number 3, when ability or status varies. When ability or status varies on the day of assessment, report what is true greater than 50% of the time unless the item specifies differently. Remember that the day of assessment encompasses the time you are in the home and the previous 24 hours. So when you're answering the questions in the on Oasis, you really need to minimize the use of not applicable and unknown. Use only when appropriate, and all efforts to obtain the information have been exhausted, because the NAs and the unknowns don't capture and support outcome information. For items documenting current status, you report independent observation of patient condition and ability, and do not refer again to prior assessment. For process items that require documentation of prior care, it is okay to review the time period at the time of or since the time of the most recent start of care, resumption of care. Okay, so strategies to obtain and complete the information, patient observation, that's bottom line, that's the critical interviews with the caregivers, patients and physicians, and your physical assessment. Recognize opportunities to gather data from multiple sources and utilize those other sources. Defining assistance refers to assistance from another person. not limited to physical contact. Physical contact includes verbal cues and supervision. For example, hands-on assistance, contact guards, standby assistance, and verbal cues or reminders. Answer Oasis items accurately based on CMS guidance, comprehensively, and follow skip patterns when indicated. The example you see on surgical wounds, if it's a no answer, then you skip to a different area. There are certain words that have specific definitions for use. For example, surgical wounds resulting from, refers to wounds resulting from surgical procedures except ostomies, cataract surgeries, surgery to mucosal membranes, or gynecological surgical procedures. I know ostomies are often questioned. We hear a lot of questions about, is that considered a surgical wound? Follow the item-specific guidance in Chapter 3 of the Oasis C guidance. And just an example of specific instructions and response. So staying current. So here are some of the resources we want to provide to you, the Oasis C guidance manual. We've given you a link, some websites. The CMS questions and answers. When I took this role on and looked up some of this, it was just amazing because, you know, in this business, nothing is ever black and white. Just when you think you've seen it all, you know, something else comes along. And so this is a valuable resource to look at and see that other providers have had the very same questions. What do I do in this situation? What do I do in this situation? And the CMS quarterly question and answers are published in January, April, July, and October. And there's a website for that. And again, I just strongly encourage you to check that out because you can submit your own questions as well as they may already be answered there. This next slide is one clinician rule I touched on. One clinician is responsible for accurately completing a comprehensive assessment unless otherwise indicated. And I've had questions about, you'll have your nurse go out and do the assessment, and then you have a nursing supervisor that will review the assessment and want to make some changes. That needs to be done cautiously, depending on what the question is or what the discrepancy and what needs to be changed. It needs to go back to the initial assessing RN for input and the final approval of changing that information because it was that nurse, and it has to be one clinician that does the assessment. Some other conventions on how to define. It defines calendar days. One calendar day means the end of the next calendar day until the end of the next calendar day. It defines that is and for example in slide 40. So it shows you something. Those are examples directly out of the manual. Again, reporting ability, not performance. Convention number 2, you want to do the level of ability that the patient's able to safely complete. An observation of the patient performing the task. A lot of times, and the time is precious, you'll ask the patient, what are they able to do? Really need to have and observe patient doing the task when at all possible. Understand what tasks are included and excluded in each item. Ensure accurate responses are based only what is expected to be included. Pay attention to the tasks, behaviors, and symptoms specifically included in each item. And then there's an example there for grooming. Reporting what is true the majority of the time, and giving more weight to tasks that are more frequently performed. Consider medical restrictions when selecting the best response to functional items such as ambulation and transferring. For example, with determining ability, if the physician may have orders for no tub or shower until staples are removed, or if a physician orders bed rest. Slides 46 to 57 refer to flu vaccine and pneumococcal vaccine data. So I'm not going to go over each and every one of them, but again, the resource manual, the guidance manual gives you and tells you pretty much exactly how to answer those questions. And then if you still have a situation that is an outlier, I'd ask that you go back to the question and answer on the website, because there have been a lot of other home health agencies that may have the same questions. So that's 46 to 57. 58, slide 58 is the Oasis Guidance Manual, Oasis C1 ICD-10 version. And then there is a CMS web-based training available for home health agency providers. I checked it out. It's wonderful. It's amazing. Believe it or not, it's amazing. It is really good, and I just strongly recommend you all go on there and check it out. And I've listed on the next couple of slides how to get to that site. I would encourage all the staff you have filling out the Oasis to do this web-based training if they haven't done it already. So that's slide 59 and 60. Again, refreshing the educational coordinators in your state. I think we're going to open it up now for some questions and answers.
Thank you, Shirley. This is Debbie. We really appreciate your insight on a very important topic. We'll turn it to the audience, and we'd love to hear from you. Do you have any questions? And we'll start by taking questions by phone and then address any questions that have come in through the chat line. I'll turn this over to the operator.
Thank you. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. If you are using a speakerphone, please leave your handset before entering your request. One moment, please, for the first question. As a reminder, ladies and gentlemen, to register for a question, please press 1-4 on your telephone. There are no audio questions at this time. I turn the call back to you.
We've received one question via chat. Many of our patients refuse to get the flu vaccine even with our repeated prevention education, even though we provide it to them. When they refuse, it impacts us negatively in our star ratings. How can we be held accountable when they are making the choice?
Shirley?
Our recommendation in your star ratings for Hospital Compare, basically all you can do is have clear documentation as why the patients are refusing. If there are a number of patients refusing, perhaps some education opportunities. But basically the only thing you can do right now is to document, to have some very clear documentation at your education of the patient or caregivers or family members as to the importance of the vaccination, and that you have provided that education, the risks and benefits of it.
We've received another one from Chad. It says, can you assist me with where to look for the risk adjustment information for the 60-day hospitalization? I see that there is a risk adjustment item. Are there Oasis questions that affect the risk adjustment, and if so, what are they?
The risk, there are some resources. Some of these questions, I would ask you all also to contact your own state education coordinators, because I don't want to speak out of turn, and there may be some specific situations that you would want to discuss with them within your own state. So there are some resources on the website, the KEYS website on risk adjustment and the use of the quality outcome tools. I don't have that information specifically now. If we can get you can provide your name or email address, and I can get it to the specific person that could help you with that. I don't have that specific information at my fingertips, but I will absolutely connect you to someone that will be able to get you that information.
Would anyone else like to put any questions into chat, or we can also open up the phone lines one more time so we make sure we catch everyone?
As a reminder, to register for an audio question, please press 1-4 on your telephone.
Again, I know that this has been just a very superficial overview, and we've just scratched the surface. I think we would be absolutely open if there are other opportunities, trainings that we could consider in the future, focusing on just the outcome reports alone would be a presentation in of itself. To go over each and every question on the Oasis tool is really not realistic, but if you have some specific training needs that we could work with the other states and HSAG, please submit those to us. We're absolutely open to considering that.
We've received a couple more questions through chat. The first one is about the webinar recording. Someone would like to know that their clinicians can listen to it. We will be providing that link. It may be early next week, but you'll definitely be able to share it. We also received this question. For PT-only cases at start, but then PT feels nursing should be added, will it be okay that PT performed SOC Oasis?
Yeah, that's okay. As the PT, again, the clinician that starts it needs to finish it, and then nursing can be added. Does that answer the question?
We'll see if they write back in.
Okay, and PT is one of the areas with nursing that they can collaborate. That's one of the exceptions, that there can be collaboration in completing that start of care assessment.
Great. Here's another question. Do you provide a resource for educational material to be used for patients relating to immunizations?
From your own, every state's or county's local health department there should be information, lots of information available on flu vaccines. Would encourage you, maybe through your state agencies, your educational coordinator may be able to hook you up with the connection to where to go for that information. But absolutely, I'm sure every state has literature available, patient literature on the flu vaccine. I think that's a wonderful idea to have available for your patients. Wonderful idea, and as you know, we're in flu season.
This is Debbie. I might add that you may want to check the HHQI website, because they have many tools and resources available for immunization, and you may find something that can be of assistance to you. If you don't have that website, we'll make sure that that's sent out to you as a follow-up to this webinar.
The CDC probably would have some excellent information also.
Yes, I agree.
We have another chat question that's come in. After the SOC visit is done, is it 5 days from the day the assessment visit or the day after that we start counting the 5-day window for the therapist to do therapy eval?
The 5 days start at the start of care date. I'm not sure. Could you say, okay, repeat the question for me, please?
Sure. After the SOC visit is done, is it 5 days from the day the assessment visit or the day after that we start counting the 5-day window for the therapist to do the therapy eval?
It's the same day, the start of care date.
Here's another one for you. We have had instances where we receive information about a patient being discharged from our services and they are unavailable to do a visit for discharge. How do we document?
You do exactly what the situation was. Very clearly document what the situation is, what the attempts were to make the visit, and that's about all you can do is just document the situation. Make sure you notify physicians and all appropriate caregivers or your team members, and you can only do what you can do. But just make sure it's documented clearly, and again, your efforts.
One final question so far that we have in the queue is if both PT and nursing are ordered on the face-to-face and referral, then is it okay for PT to go first and perform Oasis SOC, then the nurse follow with her assessment?
You can do it either way you want. That would be fine. Then PT could start, do the complete assessment, and followed by nursing. That's okay.
Great. We don't see any more questions currently in the chat. We can take one more chance to see if anything's, and here's some more come in. If a RN is ordered, RN has to do the SOC. If the PT and SN are ordered, you know what, I think somebody's actually answering a previous question rather than asking one. So scratch that. Let's open the phone lines one more time and just make sure we catch anybody who'd like to call in a question.
As a reminder, to register for an audio question, please press 1-4. We have an audio question from the line of Jennifer Wesley. Please go ahead.
Hi, we just wanted to clarify on the last question and answer that when a nurse, an RN, and PT are ordered at the same time at start of care, did I understand correctly that the PT could go first?
Yeah. Like, well, have you been told something differently? If they're ordered Okay.
Sorry, we were told the nurse was the higher scope, and so she had to go first.
I don't believe CMS. I'm not familiar with that nursing is a higher whatever. So I would encourage you to contact your state. Oh gosh, is it state of Arizona? If it is, contact me. If it's oh my, and if it's another state, to contact your state agency or your education coordinator. I am not familiar why that would be the case, but maybe there's something in your state. It's not, again, if it's our state, call me. You have my number. But there might be something in your state that they're communicating that to you. Am I blabbering here?
No, thank you.
Okay, I'm sorry, Jennifer. The other thing is, to all of you, want to keep in mind that as here in the state of Arizona, we have state rules and we have the Medicare rules. The agencies, whatever the provider type, must adhere to the most stringent. Now, I don't know in your state if maybe that's a rule somewhere else, or an interpretation, intent by your state that nursing, for whatever reason, needs to be the entering and doing the start of care assessment. So consider that also. Because if your state rules say that the nursing must do the assessment when both are ordered, that's, I guess, a more stringent rule, then that's what you would need to do.
It looks like we've come to the end of our questions, so
again, this is Debbie. We'd like to thank you all for joining us today. As a reminder, we will be sending out a follow-up email with the link to the presentation if you have not already received it. And continuing educations are available for your participation on this webinar. Just be sure that you complete the survey. We would also like to ask if you have topics of interest that we can set up webinars to meet some of your needs. We would be happy to do that. So either include it on your survey or send any one of us at HSAG an email, and we'd be happy to get something scheduled. We're here to provide you technical assistance. And again, I would really like to thank Shirley and the Arizona Department of Health Services for hosting this webinar. We hope that it's been of value and stimulate some questions and answers so that we can all work together to improve the quality of care for our patients. Thank you very much. We look forward to hearing from you.
you'll be automatically transferred to the survey as soon as you close the webinar. Thanks for attending.